Hello, everyone. Welcome this morning to join us for the webinar. We're just going to give it a few more minutes for people to actually enter the meeting room. So please be patient with us for one more minute. Thank you. So hello again, everyone. Welcome and thank you very much for joining us today. In this webinar, what we hope to do is to clear up some of the confusion around IDDSI food texture testing methods and answer some of the questions that have recently been submitted to us. We have designed the session specifically for those working in the food service area, whether in food service production, food service manufacturing, food service distribution, and we hope to be able to answer your specific questions to help to enlighten you with regards to IDDSI, the definitions and testing methods. This session is being recorded, so it can be made available to all those who are not able to join us today. All participants who have signed in will only be in a listen-only mode. If you would like to ask a question, please use the Q&A function on the Zoom control panel. So if you move your mouse around on the screen, you'll see the Zoom control panel come up, and you should see the Q&A function in the middle of that panel. When you do ask a question in the Q&A function, please identify yourself with your first name and where you are from. Our panelists will do their best to answer the questions in the order in which they're submitted. If there are questions on similar topics, we may try to answer them together so that we can get to as many questions as possible. For today's webinar, we will be providing people with certificates of attendance, but only to those who attended this live webinar. If you have joined us online, we will already have a record of your attendance, but for those who may have joined us using the telephone, please take a moment to email meetings@idsi.org so that we can make sure you receive a copy of the certificate of attendance. This webinar has not been pre-approved for any CEUs or professional development credits. You will need to check with your respective professional organizations or accrediting bodies regarding CEUs or professional development credits. So at this point, I'd like to thank all the wonderful IDDSI sponsors who have in so many years unconditionally and generously supported the work of IDDSI. And it's because of their support, webinars like these are made possible. I'm thrilled at this point to introduce our presenters to you. To the left of your screen is Dr. Katrina Steele. She's out of Toronto. Katrina is an IDDSI board member. She's also the research lead for IDDSI. Next, you'll see Dr. Joseph Murray. Dr. Murray is a past IDDSI board member, and he's currently actively leading, co-leading the IDDSI implementation in the VA in the United States. And Dr. Murray is situated in Michigan. Dr. Luis Riquelme, next on the screen, is an IDDSI board member, and he currently leads the translation process for IDDSI. Unfortunately, Dr. Riquelme cannot join us today due to situations that have come up because of COVID. And then I'm last on the screen to your right. I'm Peter Lam. I'm the co-chair of IDDSI. I'm situated in Vancouver, Canada. And it's been such an amazing pleasure to work with all of the wonderful panelists on IDDSI. I'm thinking we should just get started. here's the agenda that we have for you today. I think we'd like to talk about what is IDDSI and sharing it from a clinician's perspective to help everyone in food service understand why is it that we do what we do, or we've recommended in terms of food texture modification. Katrina's going to go into a bit more about predicted versus expected classifications when it comes to naming a texture modified food, thick and liquid. We will take a more in-depth look at the IDDSI testing methods, and then talk about why testing results may differ from expectations. And we'll wrap up to talk a bit more about IDDSI labeling, whether it's products or information or materials, because there's been quite a bit of confusion around that. And then what we really hope to do is answer your questions and to have discussions with you. We'd like to start the session off by just taking a bit of a poll of the group. So Alan, if you don't mind, I'll get you to get the poll going here. So you should see a poll pop up on your screen now. We're hoping that you can actually tell us where you're at. Thank you. We'll give it a couple minutes more. People are still voting. And hopefully you'll be able to see the live results coming in here. Okay, it looks like we're paused at the moment. Any further last minute polls? Okay, we've got people still voting. All right, I think we'll stop the poll there. And it looks like the results indicate to us that most people indicated they are aware of IDDSI and they've begun discussions regarding implementation. There's only a very small percentage that of people on the call today that said they are aware of IDDSI but have not begun discussion with nutrition and food service. So wonderful. Thank you very much for giving us that snapshot of who's on the call today. I'm now going to pass the webinar over to Katrina, please.
Thanks, Peter, and hello, everyone. So I'm going to get started with a general introduction to IDDSI and some in-depth exploration of levels 3 and 4 on the framework, and then I'll hand off to Joe to take us up the food side of the framework to the higher levels. I want to start by explaining that an important difference that exists between IDDSI and our previous approaches to classifying foods and liquids using systems like the National Dysphagia Diet. In that framework, in the NDD, you might remember that there were diets. And what's different about IDDSI is that it's a framework and it's not actually a system of diets. So there's no such thing as an IDDSI pureed diet or an IDDSI minced and moist diet. Rather, we've created these levels, this system of labels and terminology that can be used to describe the properties of foods and liquids that are available based on a set of tests. And you can see those tests listed on the screen, and they've been developed intentionally with the goal of being user-friendly so that they can be performed by anyone, whether that's those of you who are in the kitchen preparing food, whether it's healthcare professionals at the point of food delivery directly to the patient. They can be used in assessment. They can be used in people's homes by patients and their caregivers. Next slide, please, Peter. So a very key message that we want to communicate is that IDDSI is descriptive rather than prescriptive. And by this, we mean that the IDDSI tests can be used to understand the characteristics and properties of foods and liquids that are available from your kitchens and within your systems. But determining which levels on the framework are appropriate and suitable for any particular patient is something that must be based on an assessment by a qualified clinician. And so when a clinician recommends a food texture and a liquid consistency for a patient, our vision is that these represent the boundaries of a range on the framework that is suitable for that patient. And the diet can then be built using items that fall inside that range on the framework. So for example, if the clinician's recommendation is for level 5 minced and moist foods and level 2 mildly thick liquids, then those become the boundaries of a range from which the diet can be built. And that could include foods and liquids from levels 5, 4, 3, and 2. But levels 1 and 6 would fall outside that range, and those items would be inappropriate. Next slide, please. So one of the main consequences of approaching diet building and food selection in this way is that we're very hesitant at IDDSI to give examples of foods or liquids that represent the different IDDSI levels. And this is because we recognize, as I'm sure you do in food service, that the consistency of a particular food or drink can vary across all sorts of different conditions, including ripeness, freshness, temperature, and perhaps chilling and reheating processes that have been used in preparing or storing that product. And even from the time a product leaves the kitchen on a tray until it arrives with the patient, it could change in its characteristics based on things like temperature. One of the most frequent questions we get at IDDSI is a question about what level a particular food product falls into. And our response is always that depends, and that we recommend that you perform IDDSI testing to determine the answer. And to give just one example, recently I handled a question where the clinician asked, where does chocolate fall in the IDDSI framework? And so as you can see on the slide, I answered that it would really be impossible for me to answer that question and guess, because the consistency of chocolate would depend on whether it was milk chocolate or dark chocolate. It would depend on temperature, on whether the chocolate had previously melted and then hardened again, on whether there were other things in the chocolate like nuts or maybe a filling that might be runny. And so all of those considerations would need to be determined for any particular serving of chocolate. Next slide, please. So our primary motivation in developing the IDDSI framework was about safety for people who have dysphagia. And we believe very strongly, and unfortunately there's evidence to suggest that confusion regarding the characteristics of food and liquids represents a safety risk for people with dysphagia. And so our goal is to establish clear communication that reduces that risk. Next slide, please. So what do we mean by the word safety when we're talking about diets for people with swallowing impairment? Here, we're talking about the possibility that a person can swallow food and liquid without aspirating any material into their airway. We're talking about setting them up so that they can achieve good bolus clearance without leaving material behind in the pharynx, and so that they can swallow without material blocking their airway and causing a choking emergency. And so those clinical goals help us then to identify the characteristics of food and liquid that might be risky and need to be managed, such as how thin a liquid is, how sticky material is, and how large the particles of food are in a bolus. Next slide, please. So when we swallow, you and I have to be able to manage the fact that our throats actually serve as a single passage with two separate functions. The first of those functions is as a pathway for air to move in and out of our body for breathing and for speaking. And the second function is that our throats are a pathway for food and liquid to move through in swallowing. And safe swallowing requires that we reconfigure that pathway so that it stops being a pathway for breathing and becomes a pathway for ingestion. And this means that our bodies have to be able to close the entrance to the larynx, the voice box, and open the entrance to the esophagus, as well as then to execute a series of muscle contractions that move a bolus of food or liquid down through the pharynx. Next slide, please. So here we have an animation, and you can see here a bolus of food being swallowed. And if you look down towards the middle, you can see a depiction of the epiglottis closing over the airway. Thanks, Peter. So that airway is actually open while the bolus is in the mouth, but it closes as the bolus approaches the entrance to the airway and the entrance to the esophagus. Next slide, please. So in people with dysphagia, we're very concerned about what we call penetration aspiration, or the entry of material into the airway. We recommend thickened liquids for people with dysphagia because these liquids move more slowly than thin liquids, and this gives the patient that extra time they need to get the airway closed before the bolus reaches that danger zone. And several studies, including a recent paper from my lab that's shown here on the slide, confirm that the risk of aspirating is significantly reduced as liquids get thicker. Next slide, please. In this example of a swallowing X-ray or a video fluoroscopy, you see a dark line appearing down the front, and that's aspiration, where we see difficulty achieving airway protection and closure and the material getting into that airway. It's quite a dramatic example, this one. I would guess that's probably less than a third of a teaspoon of material, but that's a significant amount to have go into the airway. Next slide, please. So when using IDDSI, a clinician can recommend thickened liquids, and we need them to be clear for the people who are preparing the trays and also the people serving the food and liquid to the patient. They need to be clear about exactly how thick they feel the material needs to be. And on this slide, you see an illustration of our IDDSI flow test, which I hope you're already familiar with. And here we look at how much material remains behind in a standard 10 milliliter slip tip syringe after 10 seconds of flow. And provided that you use the correct syringe for this test, and that's important, then the test is valid and highly reliable for determining whether a liquid falls into levels 0, 1, or 2 on the framework, that is thin, slightly, and mildly thick. But if you look on the right-hand side of the slide, as we then go up the framework to levels 3 and 4, you can see a fork and then a spoon depicted on the right-hand side of that testing card. And this communicates that in addition to the flow test at level 3, we really need a supplementary fork drip test. And for level 4, the flow test actually is no longer very useful because things are too thick to flow through the syringe. And so at that point, there's a fork drip test and also a spoon tilt test. So if we can go to the next slide. Here you can see some pictures illustrating the fork drip test. And this test confirms whether a liquid is behaving more like a level 3 moderately thick liquid or a level 4 extremely thick liquid. At level 3, the liquids don't flow sort of consistently through the fork, but they will drip through the tines of the fork in dollops. And in level 4, you should see no dripping, and the liquid will actually mound on top of the fork, not drip through other than perhaps a small tail. So to demonstrate this, we're going to play a video that I recorded earlier this summer with a few foods and liquids. Thanks, Peter. So for this first virtual active demonstration, we're going to look at the fork drip test, and we're specifically interested in confirming whether a product is level 3 or level 4, or maybe not behaving as expected. I want to start with a liquid that you might have some assumptions about, which is honey. And I chose this because, of course, we used to call liquids honey thick liquids. And that's a really ambiguous term. And so I have here some commercially available honey. And I've preloaded a syringe so that I can show you how it behaves in the flow test to begin with. So I have a clean syringe here, and I'm going to fill it with 10 milliliters of the honey. So I'm at 10 milliliters on the syringe, and now I'm going to use my watch as a timer and let it drip into the bowl for 10 seconds. 5, 4, 3, 2, 1, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Now, you may have noticed that only a couple of drops came out of the syringe. Really, we're still at 9.8 on the syringe. And so this is probably in the moderately thick range, but it really didn't flow. And this honey may have a property called yield stress, where it has some surface tension and doesn't flow very well. So the next question regarding this honey is, how does it flow through the tines of a fork in the IDDSI fork drip test? To do the IDDSI fork drip test, you need to be able to immerse your fork into the bowl, and then you need to be able to lift the fork out of the bowl and observe what happens. And so I have the fork immersed in the honey, and you're going to see that really it's a very thin strand initially, and then it starts to sort of separate into dollops. So really this honey is not behaving as we would describe a moderately thick liquid. The stream is too thin through the tines of a fork, and so this is displaying a product that may change its behavior in certain conditions. Temperature would be a relevant factor to understand here as well, but really this is a little bit too thin once you apply the fork drip test. And so I've got a second liquid here that I want to demonstrate fork drip testing with, and that is a commercially available plum sauce. And so here I have it in my container, and I'm immersing my fork again, and I'm going to lift it up, and you'll see, in contrast to what we saw with the honey, that here we have dollops falling through the tines of the fork. I'll show you again. Try and get a little bit more on my fork. So with moderately thick liquids, it's actually quite difficult to load a reasonable amount on your fork because it falls through the tines of the fork. And this is a good example of a liquid that is behaving as a moderately thick liquid and dolloping through the tines of the fork. A third example I want to show you is applesauce. And applesauce is used very frequently in dysphagia management. It's often used as a way to serve pills, for example. And people have assumptions about applesauce, and yet applesauce can vary in its consistency from brand to brand. So here I have a commercially available applesauce, and I hope you can see here that it has some lumps in it and maybe some looser or more liquid components to it. And so really it's not smooth enough to meet the requirements of IDDSI level 4 in this state. If we were to do the fork drip test with this product, it can easily load and mound on the fork and it doesn't drip through. But because there are lumps in this applesauce that I think you can see clearly, it's really not meeting all of the definitions of an IDDSI level 4 extremely thick liquid. So I threw it in my blender before recording here just for a couple of seconds. And so now I have applesauce that has been pureed so that it's more smooth. And the question is, does it still test as an IDDSI level 4 extremely thick liquid, and what does it look like on the fork drip test? So here I have a fork and my product, and here you can see pretty well a stereotypical level 4 IDDSI fork test result, where we see a tail of the applesauce hanging through the fork but not actively.
Okay. Thanks, Peter. So not actively dripping would have been the missing word at the end of the recording. So now that we've looked at how thick a liquid is, we also need to consider whether it's too thick. And so there's a trade-off, if you will, or potential trade-off between being thick enough to prevent aspiration and being too thick so that material gets left behind in the pharynx. And recent evidence does confirm that if you have material already in your pharynx from a previous swallow, and then you go to swallow again, either just to clear that material or with a new bolus on top of that material, that then the risk of aspirating on that next swallow doubles. And so on the next slide, we're going to look at a video showing a patient who has residue left behind in the pharynx after their swallow. I don't know what consistency this is. It looks relatively thick to my eye, and you can see material collecting. There are a couple of pockets in our throats where this material can accumulate. One of them is called the vallecula at the bottom of your tongue. And then below that, and just above the entrance to the esophagus, is another set of pockets. There's one on either side called the piriform sinuses. We can move to the next slide, Peter. So in order to manage the risk of residue remaining behind, we need to be considering the thickness and the stickiness of the product. And for this, the IDDSI test that's appropriate to use is the IDDSI spoon tilt test. And we're going to turn again to another short video clip illustrating this test.
So in this second virtual active demonstration, we want to look at the spoon tilt test. And here we're looking at whether the product is sticky and adherent, and also whether it holds together in a cohesive bolus. And so for this, I've got those same two applesauce products that we had before, the one straight out of the bottle and the one that's been in my blender for a couple of seconds. So let's start with the one that is straight out of the bottle. And so here we're going to again immerse our spoon, this time in the product, lift it up and tilt and see if it falls off in a cohesive bolus and what kind of residue it leaves behind. So if I tilt this spoon, you'll see that most of the applesauce fell off. There is still some left behind. You can see that it's sort of collected at the bottom of the tilted spoon.
And at the top of the tilted spoon, it's cleared the spoon quite cleanly, only leaving a little bit of residue behind. So it's not demonstrating that it's very sticky. If we do the same demonstration with the blended applesauce that went through my blender, we get this result. So my spoon's in, I lift it up, it falls off in 2 lumps. This time we're seeing a little bit more coating on the spoon, but it's quite translucent and not very sticky. So both of these applesauce products would pass the spoon tilt test, demonstrating cohesiveness and not too much adhesiveness.
Thanks, Peter. So just as a sort of postscript on that video, one of the questions we get commonly is, how do you know if there's too much residue left behind on the spoon? And I think that if you think about peanut butter as an extreme example, you can imagine that it would not fall off easily and would probably leave a thick coating that wasn't translucent. And that's sort of that other extreme. Versus those two applesauces were somewhere in the middle, but not extremely sticky. So before I hand off to Joe to discuss tests for level 5 minced and moist foods, I want just to take a moment to reinforce the message that we should never make assumptions about the IDDSI level of a food or a drink based on the product name. And this is because words can be misleading. In fact, that's why we started the IDDSI project altogether, was the potential of words to be misleading. And here on the slide, I've listed just 3 situations where the name of a product might lead you to have expectations about the characteristics of that product, which might turn out to be wrong when you compare those assumptions to IDDSI testing. So our guidance is always that you should not assume the consistency of a product. And if you want to know where it falls in the framework, you should always test to be certain. This doesn't mean you have to run tests every time you create a new product, but that in a kitchen over time, you could map your menu and then do quality checks from time to time to make sure that things aren't shifting outside the expected zones. We've been actively encouraging manufacturers of products that have names on them that imply consistency to be clear in their labeling and to base any claims about consistency in IDDSI tests, and at the same time to tell us in their product documents what the conditions were in which those tests results were obtained. So for example, testing at room temperature or testing heated food. Similarly, we encourage you not to assume that labels are always correct as consumers, and to recognize that products can vary in their consistency over time, and particularly across temperature. And so to remember, if you're ever in doubt, then the safest thing is always to do a check using IDDSI's testing methods. So with that, I'll pass over to Joe.
Thanks, Dr. Steele. That was just a great introduction and review of the drink section of the 2 pyramids and the overlapping drinks and food section of the 2 pyramids. Now we move into solidly into the pyramid on the left, the foods portion of the framework. And so I'm going to review the middle levels here. And in this section, we'll briefly review a few concepts related to mastication, or chewing, as it's commonly referred to, and the effect of mastication on food particulate size. We're equipped with teeth that serve many different functions, from biting and tearing to grinding. Anthropologists suggest that when our brain grew compared to our ancestors, that the jaw moved forward and teeth actually served as a 3rd set of hands. And so we became quite adept at manipulating items, not just food items, with our teeth. And we are a species that's quite skilled at using our teeth. And so The intent when we look at our reduction of food is to use our teeth to reduce particle size, either through the biting off of a smaller piece of food from a whole piece, or perhaps grinding that piece to a smaller piece of particulate so that it is more transportable and can be advanced from the oral cavity and down through the gut. And so you can see we have a video playing here of normal mastication of foods and the advancement of that food that's been masticated down into the lower pharynx and through the upper esophageal sphincter. So the originating food particle is limited only by the opening of your mouth. And so for some people, this can be a very large particle of food. And our attention turns now not to normal folks who can reduce the very large food particle to a manageable size, but to those that may have deficits. And we'll look at this normal mastication again as it plays in a loop. We know that dentition is an important component of mastication, but we can also see that the tongue is moving very rapidly here. It's taking the bolus of food and moving it anteriorly and posteriorly. And if we could advance the slide here, we'll take a look at a slightly different view. This is called an anterior posterior view, and we can see a different plane as we watch the activity of mastication. And in this video, what we can see is that the tongue is very actively moving the bolus from one side to the other and reducing the particle size through its movement. So it's not just dentition that is responsible for reducing particle size. You really have to have an integrated unit of the tongue and the teeth, and good sensory motor control, and good sensation, and good cognitive ability to realize what is in the mouth and what needs to be reduced further. And so during this process, saliva is introduced to lubricate the food and ready it to be propelled further into the distal pharynx. Once lubricated, we can accelerate it through the bottom of the throat there and down into the esophagus, where it is advanced to the stomach and then prepared as nutrients to be used by the body. And we can advance further now to the next slide. So we have a general idea that oral processing behavior and eating rate can impact nutrient intake and, as a result, body mass index. And so we have to have these different components of a healthy swallow and food reduction in place to positively affect food intake and food choices as well. And so we'll be looking at a subject's dental status, their jaw muscle activity, the bite force that they can produce as they come in contact with food in the environment, the tongue pressure. We saw the tongue movement and the range of motion of the tongue as it moved the bolus back and forth, and of course, oral volume as well. And if someone's healthy and whole, they'll be able to achieve a status of being well nourished with very little effort. In these individuals, there's a robust reserve of strength and function, and with that comes ability to make a wide range of choices of foods that they can interact with and reduce to a manageable bolus that can be advanced for nutrition. As we age, we're more likely to become less robust, and we will experience a reduction in the functional reserve that allows for a wide choice of foods to be rejected because we may not have the strength to consume them, or we may not have the other components that integrate to allow us to consume different food types that are more challenging. And so when aging is added to a disease process, there's a synergy of disability. So 1 + 1 = 3. Let's advance to the next slide if we could. So disability can negatively affect food intake and choices. And again, if we just look at simple aging, we know that there's a reduction in the number of teeth. And so someone may be edentate or experience edentulous as a result of the loss of their teeth, requiring either prosthetic dentition in the form of dentures or bridges or tooth implants, or surrendering to their edentulism and reducing their food choice as a result. There may be reduced saliva flow. And one of the things that we know from ample research in this area is that elders experience a change in the morphology of the saliva producing glands in the mouth and the throat. And as a result, food doesn't become as well lubricated in elders. When we add perhaps an iatrogenic cause, or a cause that may be a result of therapy, like just about any drug therapy can have a result of xerostomia, or a drying of the mouth, or a lack of expression of saliva through the salivary glands. We have a mouth that's dry and that cannot lubricate the food adequately to advance it through the pharynx and then accelerate it through the lower pharynx and into the esophagus. And so there may be pain that's associated with chewing harder foods if you're edentulous. There may be a neuromuscular disease that leads to weakness of jaw motion and bite force, further reducing food choices or inducing labor in attempting to consume these different items. And again, we talked about iatrogenic causes of reduced salivary flow, but also structural changes and weakness that can occur because of surgeries, for instance, in head and neck cancer populations. And with all of these, if there's more effort involved in biting and tearing and chewing and lubricating food and advancing it back, there's going to be fatigue. And with fatigue comes an early surrender at the dinner table or during any interaction with food, and an associated reduction in oral intake and poor nutrition. We can advance now to the next slide. And so our effort here really is to emulate the effect of well-integrated mastication and well-integrated salivary flow, well-integrated tongue movement and strength of the oral musculature. All of those components are going to need to be emulated in our production of the food. So we need to replace those processes of particulate reduction and moistening of foods as we consider creating foods in this middle part of the framework. It takes some work, and it takes a considerable amount of fine tuning, but with attention and creativity and teamwork, most care environments can create dishes that fall within the descriptors of the framework. As we were implementing IDDSI in our hospital system, we had many, many meetings with the chef. We can see our chef there at one of our test tables that we held every Thursday. They're held every other Thursday now, where foods were created from the main dish and recreated and manipulated to create different dishes within the framework. Everybody took part. The chef presented the foods, described them. We have an array of folks here. We have the head of the kitchen as well. We have registered dietitians. We have clinical dietitians. We also have the fellows that deliver the food to the bedside that attend these sessions. We give them little scorecards where they can rate the pleasure that they're receiving from the dish, any criticisms they may have about the quality of the food or the changes in the reduction of particle size that may affect the mouthfeel or the quality of the food. And so this is an opportunity to examine very closely attempts to manipulate the food to create these middle framework food items. And the chef is very willing to receive that advice and make adjustments. And we've actually been able to fill all of the levels of the framework very nicely for our patients with very good results, with input from a wide range of folks in the hospital that interact with the food and interact with patients consuming the food. And so having these sorts of events is very useful. Let's go to the next slide if we could. We're going to be talking now about level 5. Again, we're moving out of the liquids, the overlap of liquids, and we're in the left triangle here in the food triangle, and we're going to talk about the first solitary level 5, minced and moist. This particular portion of the framework describes a food that could be eaten with a fork or spoon, could be eaten with chopsticks in some cases if the individual has good hand control, could be scooped and shaped into a ball shape on a plate, for instance. It should be soft and moist with no separate thin liquids. Small lumps may be visible within the food. For pediatric patients, we're looking for a particle size of 2 millimeters in width and no longer than 8 millimeters in length. For adults, this would be equal to or less than 4 millimeters in width and no longer than 15 millimeters in length. Lumps should be easy to squash with the tongue. And so this would be reserved for patients who present with an inability to bite. Biting is not required here. Minimal chewing is required. Tongue force alone could be used to separate the soft and small particles in this texture. Tongue force will be required to move the bolus out of the oral cavity and into the pharynx. This may be good for patients that have pain or fatigue on chewing or that have missing teeth or poorly fitting dentures. We can advance a slide. Well, I'm sorry, we can go back. I was one behind. And so with the measurement for this particular portion of the framework, we can employ a fork. The particle size matches food particles that have been reduced from whole foods following a normal cycle of mastication. And Dr. Steele's lab actually has produced some work where they've looked at whole foods that have been masticated, then expectorated and inspected. And the particle size is in the range of about 4 millimeters. And so we're looking to emulate a reduction of the whole foods down to this level to assist patients that have trouble with chewing. Now you could use a ruler to measure the particle size, or you could use the index cards, which have a 4 millimeter gap printed on them. But there's something much easier to use, and conveniently it turns out that the slot or gap between the prongs of a standard dinner fork are approximately 4 millimeters wide. So this provides a very easy way to judge the particle size. And so what we'll do, as you can see in the illustration, as you press the fork against the plated food, you should see these particles emerging between the tines of the fork. If the particle size is too large, of course, it will not press through the tines. And so very convenient, and I think very clever on the part of the board coming up with this measure for monitoring foods. So I can say that the addition of the minced and moist food items on our menu has been a real boon for patients. The process to achieve a puree texture often includes some sort of mechanical pulverization of the cellular structure of the foods. And so with puree foods, oral manipulation of the food offers no opportunity to express natural fluids from the structure of the puree. The liquid becomes suspended throughout the puree texture, and there's no pleasure in manipulating this in your mouth in expressing the natural juices. In level 5, however, with the minced and moist texture, there's enough of the remaining cellular structure to contain liquids and juices that can be pressed out of the food, to create a mouthfeel that matches the whole food. Even people without dentition can further crush and express the liquid from these particles, offering a more natural and pleasing texture for oral intake. And I can tell you that patients have voiced that they find this to be much more pleasant than puree constructions of the same food. We can advance the slide. Here's a couple of examples of attempts to create dishes that match the 4 millimeter particle size. This is a chicken tetrazzini that was created using small pasta pieces rather than larger pasta. It's separated nicely. We can see that the reheating process left some crustiness on the outside that didn't reduce quite as well. And so that was a note that the chef made, and in subsequent constructions of this dish, it was considerably more moist. We can move forward. And we can see this is another pasta dish. I think this was a lasagna that was recreated using an orzo. Similar problem with reheating, although not quite as dramatic, but nice particle size, excellent mouthfeel for the patients who can get that natural pasta feel and taste as they crush the smaller particles of pasta between their gums, for instance, if they're edentulous. Let's move to the next slide. Here we can see a cod dish, and this is cod that's been reduced. It passes the fork tilt test, the spoon tilt test that Dr. Steele described earlier quite nicely. When we use the fork, we can see that the peas and carrots here that have been reduced get pushed through the fork rather nicely. We take the largest piece, place it on our testing card, and we can see that it falls within the 4 millimeter adult range for particle size. And so that is a positive finding and a secondary test following the fork pressure test. We'll go to the next slide if we can. And now we'll take a look at IDDSI level 6, and this has a slightly larger particle size. In level 6, the particle size is intended for patients who have a greater ability to masticate food. For soft and bite-sized textures, we can again employ the fork to determine how soft the food particle is. Research has shown that approximately 15 to 20 kilopascals of pressure is exerted by the tongue against a bolus of food in the oral cavity during the process of advancement of the bolus. It's important that we make sure that the bolus of food will comply to those forces, and so we need to emulate that. If we press a fork with our thumb against a sample of food, we hope to see some imprint of the fork tines on the food sample. And again, we're lucky to have Dr. Steele doing some excellent work in her lab. She found that 17 kilopascals of pressure is also the amount of pressure needed to achieve a blanching of the thumbnail, which is what we can use to determine how hard we're pressing against the fork. And of course, the fork in turn pressing against the sample of food. When the sample's pressed with the tines of the fork to a pressure where the thumbnail blanches to a lighter color, the sample squashes, breaks apart, changes shape, and does not return to its original shape when the fork is removed, if it's soft enough to be described as qualifying within the framework, the language of the framework. And so you can see the thumb pressing here in the lower left-hand corner of the image. And we can see where the tongue might be pressing against the bolus, against the hard palate as it starts to advance the bolus back into the pharynx. And so this introduces us to some more visual examples of the advancement of food and liquid. We'll go ahead and advance the slide. We can see here a laryngoscopic view on our left, a fluoroscopic view on our right, just to familiarize you with the view. The laryngoscope's placed transnasally, as you can see that line there going through the nose and down into the pharynx. It's achieving the view we see on the left, which is our airway. This is a very small structure. And if we advance the slide here, we're going to see the airway again. The airway or the larynx and the glottis, which is the delta-shaped opening there, is the conduit for air as it passes through the pharynx down into the lungs. And so just below that delta shape is the trachea, and below that further is the lower airways of the lungs. The larynx is firmly in the pharynx, and it serves a function to protect the lower airways. So the larynx rises above the floor of the pharynx and acts in a passive way as a barrier to the lower airways. It creates a shield effect. It acts much like the prow of a boat, or if you live in the north, perhaps you've seen snow plows push snow around a truck as it clears a street. And so the laryngeal structures in the epiglottis, that's a leaf-like structure that we see, serves the function passively of just directing food and liquid around the lower airway. So the larynx, the surrounding laryngeal anatomy, passively protects the lower airways. The airway is approximately 1.8 centimeters squared in an adult. If we're sitting upright, it increases slightly. If we're laying supine, decreases slightly. There's some changes with head position as well, but generally when we're looking at an adult airway, that glottic opening, or the opening going down to the lower airways, is approximately 1.8 centimeters square. We could advance the slide again. And so we can see here, this is some milk arriving down in the pharynx, and we can, if you just press the button, you'll see some oops, okay, that's fine. I think if you take a look at the image here, you can see how nicely the larynx is passively protecting the lower airways. This is some milk with a little bit of green dye, and you can see that the structure, without any activity, will guide food and liquid around the lower airways. Let's advance the slide here. Now we're going to take a look at that same cod dish, and this cod dish now has been manipulated to meet the soft and bite-sized particle size. And as you can see, this particular dish has failed. The particle is too large to match the 15 millimeter square. It should be about the size of a thumbnail. The carrot pieces easily match the size. The pea easily matches the size in its serving state as well. And so portions of this dish matched soft and bite size, and portions did not. And so notes were made to reduce particle size with good results that followed. Let's advance the slide if we can. And so now we're taking a look at a patient with good dentition. I think you can see lots of teeth there in the oral cavity, but real poor mastication. And so this could be a result of poor cognitive ability, perhaps reduced sensorium, any number of reasons why this bolus perhaps is not being guided in the oral cavity to be masticated, but we can see it is not. And it is a fairly large lump of food, and it's falling into the laryngeal airway there. And you can see there's a great risk of asphyxiation with a food particle that size. That could occlude the airway and result in a choking event. And of course, require emergency intervention if the patient's not able to clear it from the airway. Aspiration and choking asphyxiation are key safety issues in children and adults that have swallowing problems. And specific food characteristics, specifically the texture, size, and shape, are associated with increased choking risk. Across the globe, deaths in all age groups have occurred from choking. There have been incidents where this was due to misunderstanding and miscommunication with the use of diverse, inconsistent, and sometimes confusing terminology regarding the safest and most appropriate food texture for an individual. Aspiration can lead to pneumonia, requiring hospitalization, and for the elderly or compromised individuals, a severe pneumonia can lead to mortality, which is our goal is, of course, to describe food textures that reduce this sort of risk. And so let's advance to the next slide. Many of us are informed now that choking risk increases as the particle size of the solid texture increases. And so we may be tempted to assume particle sizes fall within the framework in prepackaged foods. Let's do a little demonstration employing the laryngoscope again and look at particle size and the potential for airway occlusion. Let's advance to the next slide. This is this is me. This is my larynx here. And I'm going to be taking some peach pieces from a diced peach container. We can see that we have a piece that falls within the 15 millimeter square sizing that we have printed on our index cards. This is going to be advanced back into the pharynx. And we can see it being held back by the epiglottis here. It's not advancing further. There's just enough of a chink between the base of the tongue and the epiglottis to hold this food particle at bay until a swallow occurs, and we can see the swallow occur. Now, this is a very small diced peach. We're looking at a just slightly larger one, and we can see that this diced peach actually extends beyond the 15 millimeter square index card demarcator. Now, when this is advanced down into the pharynx, it looks like the Rock of Gibraltar, and we can see that the epiglottis doesn't contain it well. It's going to slide right into the laryngeal airway, and it's large enough to completely occlude the airway, as you can see. And we can see it's expectorated through a cough. We'll just take a look at this again in a stilled fashion. We can see it completely covering the glottal opening, completely covering the airway in the larynx. And so very dangerous situation. Luckily, I have an intact sensory system and a strong cough, and I was able to expectorate it, but we can't take risks with those who have less ability. Let's advance to the next slide. We'll move now to the easy to chew texture. This is a subcategory of the top level of the framework, and this subcategory was introduced following global requests from end users to have a category for softer foods for people who have mild issues with oral processing or may show slight fatigue during chewing. It's not recommended for people who are at risk of suffocation due to incomplete chewing, taking too large a bite, or eating too quickly, as the particulate that might be left over could easily asphyxiate the individual. And so we talked about that just a bit before this. Fork separation test and fork pressure tests are used to determine if food is soft enough, it can be easily broken down. And so we'll advance here and we'll take just very briefly, we can see this person is able to chew easily and propel the bolus into the upper esophagus. The airway is clear, and so a nice soft bolus and is easily masticated. Let's advance the slide. The fork pressure test we talked about extensively. We can also use the fork spoon separation test, where we'll use the side of the fork or spoon and press it against the food sample to determine if it can be broken apart easily. And so we always have to think about the risk for choking relative to particle size here. And so the key for an easy to chew item is easy reduction with the side of the fork or the spoon. So let's advance this slide. So let's just reflect on this left side of the triangle. Safe swallowing is dependent on appropriate oral preparation of a bolus, efficiency of the propulsion of the bolus, speed of the onset of the swallow, good integration of the sensory motor system. We know that many of our patients do not have all of these components of safe swallowing. And so manipulating texture reduces choking risk by reducing particle size. It facilitates breakdown of the food in those with poor mastication and increases efficiency and reduces fatigue in those that have problems with these different components of food reduction. And with that, I will hand it over to Dr. Steele.
Thank you, Dr. Murray. And I should just say that those of us that watch Joe almost aspirating that piece of peach are always horrified. Don't try that yourself at home. So I'm going to close off around testing by walking you through 2 more categories. But first, just to illustrate here the variety that we see in normal oral processing. So not all of us chew and reduce food the same way. What we've got here are pictures of baby carrots that completely healthy young people have taken into their mouths and chewed 20 times and then spit out the carrot. And you can see here that across those 20 chews, we do see quite a bit of variation in the product. You can see changes in particle size and how well reduced it is. You can see also differences in moisture. But I hope you can agree that we think that level 5 minced and moist on the framework probably is a pretty good match to what we typically see after normal chewing and oral processing with solid foods in healthy people. So we can go to the next slide. There are 2 other categories we want to draw your attention to, and the first of those is transitional foods, which when you're looking at the framework appears on the side of the upper pyramid as a sidebar. And transitional foods are foods that begin as one consistency, usually up in the level 5, 6, or 7 range on the framework. But then they change either due to temperature or to mixing with saliva so that they become thinner. And there are lots of examples of these foods. You can think of ice chips melting, ice cream or Jell-O fall into this category that will melt fairly quickly in the mouth. And those can move all the way from a level 7 regular solid to a level 0 thin liquid, depending on how long they sit. Other examples might include things like potato chips or wafer cookies, as shown on the slide. And these, we talk about them dissolving from solid to more of a pureed level 4 type consistency, even if all you do is just hold it in your mouth and don't chew. And these products are often used with children who present with developmental delays or disorders, or with adults who need rehabilitation for chewing problems. So in terms of knowing whether these products are suitable for a person with dysphagia, the clinician needs to think about the consistency, not only of where it starts, but what it becomes after it has transitioned. And so if, for example, we were talking about ice cream that might start at level 7 and transition all the way to a level 0 thin consistency, then the question would be, is it safe to give that product to a person who needs level 2 mildly thick liquids? It's not a question that can be assumed that all people who need level 2 mildly thick liquids couldn't tolerate ice cream. It's something that should be evaluated by a clinician. And a key thing there would be timing. So how quickly after they put the ice cream in their mouth do they swallow? And does it sit around for long enough that it becomes so thin that it would be a safety risk? So it's really a very clinical determination. Let's move on to the next slide. In terms of texture evaluation with transitional foods, there are a few approaches. The one we've recommended in IDDSI takes the food in its original state, and then we change it by adding water to the sample, just a little bit of water, and waiting for a minute, and then applying the fork pressure test to the sample to see how it's behaving. And then, as with the fork pressure test that, as Joe described it, if the item compresses and then the sample doesn't return to its original shape, then it would be behaving in that level 6 range. And if you think the food has transitioned further than that, then you would apply the tests that are appropriate for the level that you think it might have transitioned to. Another approach that is not as attractive to consider, but may be important clinically, would be for somebody, perhaps at these food panels, such as the one Joe was describing for testing food, for people to actually put the product in their mouth and either let it sit or perhaps chew it a little bit and then spit it out and see what level it has transitioned to during that process in the mouth. Next slide, please. So the final category of foods we want to discuss is mixed consistencies. We get a lot of questions about these foods, which include things like soups, for example, where there is perhaps a solid floating in the liquid. And so mixed consistencies are products that have more than one texture or consistency in a single serving. And they can be dangerous for a person with dysphagia because the liquid portion can separate away easily from the food portion, and this becomes difficult to coordinate. And so when you're testing these, it's important to look at both the food and the liquid components and to ask whether those match the range of IDDSI levels that has been recommended for that patient. And if you're not sure, then this again is a situation where the clinician should be asked to evaluate the person's ability to manage mixed consistencies. For example, we've had questions about gravy on top of mashed potato, for example. If that gravy is already thick and falls within the range recommended for the patient, they may be fine with it. But if it's thin and runs away from the solid component, then it may be not recommended. Let's move to the next slide. And here's just 3 other examples of mixed consistencies. So Joe showed us what happened with fruit cocktail portions of the solid pieces, but of course, often there's a syrup around the fruit that could easily flow away from the fruit. And in fact, there are fruits that, and just by themselves may behave like mixed consistencies. So things like watermelon, where on the first bite, the juice squirts out from the solid, that would really be behaving like a mixed consistency. So again, it's important to look at both the food level and the liquid level that are represented in the food and whether that matches the range that is recommended for the patient. Next slide, please. So to help you with knowing which IDDSI tests are recommended or required for different consistencies, we have made a large number of different resources available on our website. And one of those is this great testing reference guide that shows you for each level which tests are required. We also have audit tools that illustrate the required tests similarly. We have a couple more slides showing the resources. Here's a master poster that, that contains all of the levels, the descriptors, and the required tests with instructions. And the next slide. We have testing reference cards in the next slide, and also smaller business card resources. So all of these materials are available for free, and we encourage you to download them from the website and produce them in your facility. With that, I'll hand back to Joe to discuss implementation.
Very briefly, I'll go through this to allow time for questions. So we'll just go to the next slide if we can. This is part of our implementation, not just at our hospital, but system-wide. We've actually implemented now IDDSI and gone live almost throughout our entire system. I work at the Veterans Affairs Medical Center here in Ann Arbor. I'm part of a much larger healthcare system delivered by the US government to veterans of military service. We have 364 sites that serve food and corralling what amounts to thousands of people to deliver the new framework for patients with swallowing disorders was a big task, and it was a system-wide task that needed to be tackled in a a very organized way. And so staff education and training is essential, not just initial training, but recurring training as well. Everybody that comes in contact with a patient who puts a spoon or a fork up to their mouth or takes a drink from a cup should be informed about the IDDSI framework. And so that's registered dietitians, speech therapists or speech pathologists, OTs, PTs, physicians, nursing, and food service employees across the spectrum of the food service employees. Very importantly, the individuals who deliver the food to bedside. They are the guard against misplating and delivery. And our fellows here in our hospital, at least, have really taken this upon themselves to serve that function. And they know the framework well and what those plates should look like. So who does the training? Well, there should be a local IDDSI implementation team set up at each site. In most of the VA sites, it's either registered dietitians coupled with speech pathologists, but it really depends upon who's doing the work at different sites. We can advance the slide. We have to remember that it isn't just an inpatient effort, but we also have to take care of our outpatients. And so the registered dietitians have taken it upon themselves to develop a toolkit for patients and caregivers to take home. And in this particular toolkit, you can see there's forks and spoons, IDDSI test cards, instructions for thickening liquids, individual packet samples, as well as a large jug that can be used to create variations of mildly thick or moderately thick liquids. And so creating a take-home kit like this makes it much easier to provide instruction and assure safe transition from inpatient care to outpatient care. We could advance the slide. There was a question about using syringes. We're suggesting that you use Becton Dickinson syringes. You can go to their website to look up the syringes. That's www.bd.com. That's Becton Dickinson. And we'll have information about the syringes there. You can use a slip tip syringe. Their product number 303134. Or Lorlock syringes, 10 ml Lorlock syringes, 302995. And those, I think, are fairly easy to acquire. You can go to the website, talk to your supply and distribution group in your hospital to determine how it may be acquired and distributed. If we could go to the next slide. Right, it's important to include pharmacy and to make sure that language is used in their computerized medical record that identifies thickened liquids according to the IDDSI framework. Make sure that that language is updated. You also can create order sets in the different software packages that may be available. Don't forget that component of the transition. It's a very important one. Physicians, nurse managers, physicians' assistants need to be able to order the correct diet, and the order system should reflect the IDDSI framework. So don't skip that step. I'll hand it over now to Peter, I believe.
Thanks very much, Joe. Thanks very much, Katrina. We thought at this point, we just take a really, really quick poll to find out, now that we've talked about the food texture modification and focus, how ready do you feel in terms of implementing? So if we could just get people to vote, that would be great. Thank you. We'll just give it a minute more for the results to come in. And again, to find the poll, you should see it near the middle of your control panel. The Zoom control panel. Okay, looks like we've got. All right, I think we'll just pause it there. Alan, if you could show the results. Great, the results are showing us that most people are feeling, that they're mildly ready, but quite a majority are feeling, between moderately ready and extremely ready. So thank you very much. We really, really appreciate your polling results to just tell us where people are at and how they're feeling. So we'd like to just pause now, I think, and take some questions. Questions have been coming in already through the Q&A function. And so let's just jump right into those and address your questions. There were a couple of questions that came in terms of which syringe is the correct ones to use. I think Dr. Murray's already answered those. The numbers that were shown in the slides, we'll just back up to those. These numbers here are the numbers for North American packaging. Those of us joining us from the European community, the number is actually 305,959 would be the Lurlock syringe that is available. And then I believe that in the area, just looking for the number now, in Germany, there's actually a product that has CE certification as well. And that one with the CE marking is 300912. So 305959 is one model that's available. And then 300912 is the other one that's available in the EU area. Moving on to the next question. Jennifer asks, when we review the IDDSI framework, it does not appear that transitional foods are allowed for consideration for level 4 pureed. Are we understanding this correctly? Because of this, we have been having a bit of confusion and discussion in our network regarding patients requiring level 4 pureed solids, but cleared for thin liquids, and whether clinical judgment can be used to allow items such as ice cream and sherbet. Katrina, I'll hand that over to you.
Thank you. This is a great question, Jennifer. And the answer is not terribly straightforward. So first, I'll just highlight your last point there, whether clinical judgment can be used to allow items that might fall outside the range. So in this case, ice cream or sherbet. So the answer is that clinical judgment can always be used. And it is clinical judgment. So then the clinician is indicating that they believe an exception can be made to include an item that doesn't fall within the recommended range. Of course, that's a decision that they should make carefully. On the other hand, if the clinical assessment has determined that a person has risk with items from levels 5, 6, and 7 on the framework, and that their food recommendation is level 4 pureed, then serving them something that is more solid than that does involve risk. And so this is where I was referring to needing to observe, take into consideration what do they do with that item. So if it's a potato chip, for example, I think as a clinician, I would be more worried about that than I would be about ice cream, because ice cream melts relatively quickly and changes in the mouth into a more liquid format. So it is a judgment issue. We, as a rule, would exclude ice cream and Jell-O and transitional foods from people who have a recommendation for level 4 foods and whatever their liquid level is, but exceptions could be made on an individual basis.
Thanks, Katrina. I think I'm also going to add on to that because, again, as Katrina mentioned at the very start of this webinar, sometimes the names of foods can be deceiving. For those of you who have never, well, I hope you never have done this, but if we're looking at something like pudding and instant pudding, and because the thickening agent is mostly a starch modifier, if you had too much saliva come back into the container of pudding, the salivary amylase from that saliva can actually thin out the pudding over the course of the meal or over the course of the time that somebody's actually eating it. If you like to, see this for yourself, let me challenge you to taking a serving of pudding and just spitting into it, and then just let it sit. And over the course of 5-10 minutes, you'll see how the pudding will actually thin out over time. And so that's the reason why the IDDSI testing methods are so important, not just for a food service production perspective, but also as a way to allow people who do the actual assessments to be able to communicate more clearly with those of us who are preparing the food, serving the food, and monitoring how the person does during their eating and drinking. So just food for thought. I know I've provided a pretty gross example, but that's something to think about. We have another question. Sonia, thank you. You had asked, I had understood it was better to spoon the product onto the fork rather than to scoop it up. Any truth in this? So we had initially—
So I can just answer no.
Sure, yeah. In discussion with the food scientists in our group and with Dr. Ben Hansen, who has extensive experience in rheology, it was recommended that we should actually scoop it up, or actually run the fork through the food, because it better simulates how we actually manipulate and work the food within our mouth. Sometimes just the surface tension of the food when we scoop it up and place it on top of the fork actually allows it to have a bit more of a cohesive nature to it, rather than when we actually run the fork through it. And so our recommendation now is that when you perform the fork drip test, is to put the fork into the food and use that to scoop it up. So moving on to the next question, Samar from Saudi Arabia, thank you for your question. Are we expecting outpatients to have ongoing food drink testing for their food, especially with any new products? Katrina, passing it over to you.
Sure. Thank you, Samar. This is a great question. And I think Joe has already spoken a little bit about this with the home kits that he showed on the slide. One of the things that we are so excited about with the framework is that the testing methods are easy enough that they can be taught to practically anybody, and that really empowers outpatients and their families to evaluate food in their home and decide whether or not it is suitable or might need to be modified. So we would highly encourage those of you that are working with outpatients or people who are about to be discharged to introduce them to IDDSI and to the testing methods. In addition to the resources I showed you, we also have an app that is free and available for both Apple and Android phone systems. And so that gives video examples of all the testing methods. And so we would encourage people who are leaving the hospital and going home to learn the testing methods and to be educated about the optimum characteristics for their diet, so that they can then look at variety and increase their variety at home.
Thank you, Katrina. We know that it's 1:30 now. We have just a few more questions that we're going to address and then wrap up, if for those of you who are able to stay with us for a few extra minutes. Chris from the UK had asked, can a sandwich be modified into a level 4 pureed? And Chris, the answer is absolutely yes. Anything can be modified into whatever textural level. The key thing would be, will it behave like what we would perceive as a typical sandwich? And the answer would be no, because with a pureed level food, typically we would be eating it with a spoon, and we would want that particular modified sandwich to be checked with the spoon tilt test, looking at the particle size. So once again, go back to the IDDSI detailed definitions for what a level 4 food should be. Katrina had talked about a little earlier in terms of the, how the name of the food can be a bit deceiving. In the past, we have talked about things like pureed bread. In our special feature from last month's eBite, we had, or September's eBite, we had talked about pureed foods that can be picked up can actually present a choking risk. And Dr. Murray was kind enough to show that video where a solid piece of food can actually fall on top of the airway and cause choking. And so just something to think about when you're naming a food pureed, that something that's over solidified or gelled to a point where it can potentially present a risk for occluding that airway will not be considered a level 4 pureed. Question around Andrea, thank you. Can rice be incorporated into a dish? If so, which grain is best? And once again, I think we want to say to you, go back to your IDDSI testing methods. Yes, we know that rice has been successfully incorporated into dishes, casserole type dishes. Again, it depends on the recipe, the cooking method. How hard is that grain, and how does it separate out of that particular dish when or the mouthful of food when it's being manipulated? How cohesive is it? This is the same thing that we would consider with any foods that have finer particulates, long grain or short grain. And again, I think it's it's always dependent on how you're preparing it, what's available to you. So this is why we have reference groups and community groups starting to come together to talk about some of these things. And we hope that for those who have these outstanding questions, join up with one of your regional or national reference groups that's coming together, and hopefully some of those questions can be answered on a more regional level that may be suited more to the cultural offerings in that area. And then I think we have a few people asking about joining up with other groups. We'll move on, I think, at this point, just to talk about the fact that we have these resources and references on our website about how to label products, because one of the things that we want people to be aware of is consistent communication and labeling. And by doing the consistent labeling, then we can then be able to communicate in a more effective way. We also have these available on the website in terms of guidelines around how to create materials. We ask people to please not use the IDDSI logo itself on your materials, because we don't want people to misunderstand and perceive that that is some product that has been created by IDDSI. Feel free to use the IDDSI framework with the appropriate citation. Feel free to use any of the triangle icons. All of these are available to you on the IDDSI website. I think just in closing, we'd like to say to you that, as Katrina had mentioned at the very start, IDDSI is not a prescription. It really isn't like the way the old national dysphagia diet was used, where when we said, oh, Mr. Jones is a pureed, where there's a foods allowed, foods not allowed list. What we really, really want people to be mindful of are the testing methods, because IDDSI is a way to describe how food behaves. IDDSI has some standardized testing methods for you to use to check how that food behaves, because the same food, depending on how it's prepared, what temperature it's cooked at, what moisture content is there, how ripe it is, may behave very, very differently. And so compared to what we've been used to all these years of foods allowed, foods not allowed, we really are challenging you, encouraging you to think about the testing methods that are being employed. Please go to our website for more information. As I mentioned before, there are reference groups coming together looking to address issues that are more focused on a regional, national level. Please watch for more announcements in the IDDSI e-bites and join up with one of these groups if at all possible, and be able to share and discuss more of these questions that have maybe come up after this presentation. To close, really, I think we want people to remember that the key reason why we're doing all of this and why all of us are putting the energy and effort, and that's really around safety. We want to promote safety. We want to help improve safety through the use of common terminology for everyone. And that's the reason why we host webinars like these. So thank you very much, everyone, for attending today. We really, really appreciate you taking the time. A recording of this webinar will be available on the IDDSI YouTube channel within a week or so. If you wish to watch it again or share with your colleagues who weren't able to attend today, visit the website for resources, sign up for the e-bite if you haven't done so. We only send to you important updates or news, and we never spam you. And so if you wish to participate in an IDDSI reference group, or if you don't know if there is one in your country or region and you want to start one, please contact us. We would be happy to hook you up with one or help you get one started. Just put in the subject line of your email, interested to join or interested to start an IDDSI reference group. And then finally, just one last reminder, certificates of attendance will be sent out to all participants who joined us for the live webinar only. If you happen to be watching this on the YouTube channel after the fact, please do not contact us for a certificate of attendance, because we don't have a way of verifying that you actually had attended or watched the webinar. So on that note, thanks again, everyone, for joining us. We hope that you will keep safe and well. So until the next time, have a pleasant day, and we look forward to seeing you again.